professor of rheumatology in Newcastle University in the UK, and he is a member of our medical board. He's talking about fatigue this afternoon. Thank you very much for being here.
Well, thank you very much, and it was a pleasure for me to be in Athens with you guys today. And so it has been, this is something that we talk about patient's perspective. I can tell you this is how patient changed my perspective. When I first started being a consultant in rheumatology and looking at Sjögren, I did a PhD in immunology. I was thinking about, I'm going to be a laboratory scientist, going to be winning Nobel Prize. No, not never. But actually, once I actually met all my patients, everyone was telling me about fatigue. So my research has changed into doing fatigue. So, this is really the power of our patient. Anyway, so I'm waffling on, so I'm now going to move on to my presentation. So these are the conflict of interest. And so today I was just going to say, in the next 20, 25 minutes, I'm going to talk to you about 4 points. So firstly, about fatigue being an important unmet need. And then secondly, we touch on about the possible causes or contributing factor of fatigue in Sjögren. And then we briefly touch on a possible way of managing fatigue. And finally, because the topic for this first conference is about today and tomorrow, so I want to talk about something about challenges, but also potential new approaches that we may be able to assess and monitoring fatigue in Sjögren. Okay, so many of you would know that, we all talk about Sjögren. The first thing people thinking about is dry eye and dry mouth. That was what I was told when I was in medical school. And then, of course, I was introduced to the concept about lymphoma. So this is the most important problem we need to solve. And then, of course, we learn about the systemic or extraglandular manifestation. This has always been a topic for the last few years. But day-to-day clinical practice, I have to say, this is what people keep telling me about, that doctors, can you not help me about my fatigue? So now I'm not saying that any of the other clinical features are not important, but this is certainly one of the areas that I don't think we get an answer, and we need a lot more research into it. So why is this important? Because first of all, it is very common. So between 55 to 70% of the patient will report a significant level of fatigue. Now you can use different scale. We'll talk about defining fatigue later on. But also, from a patient perspective, really, fatigue is the top priority. They think that they're in need of improvement. This is what they're really limiting their day-to-day life. We have a lot of data showing that it's really the most important factor associated with poor health-related quality of life. And we know that it also has substantial both direct and indirect health costs. Now, although the data from the US in 2007, although this is not specific for Sjögren, you can see that it's estimated more than 100 billion of excess annual direct and indirect costs is due to fatigue in general. So this is not really a problem just for the patient, but also for the healthcare provider, but also for the society as well. Now, this is also quite an interesting survey that came out from using social media posts. I thought it was actually coming from the lady sitting next to me, but I realized it's not. But anyway, so I'm going to talk about some of those. So these are some of the data that people analyzing the social media posts. Nearly 27,000 social media posts from US, Canada, Australia, UK, France, Germany, Italy, Spain, and in China. They are using AI approach to analyze the commonness and bothersomeness. So you can see in here, what they actually find is that you can see fatigue, it is in here, that both they are very common, but also extremely impactful from the patient perspective. What is also quite interesting is that when, from a patient perspective, what they talk about flare, I know that tomorrow you have a workshop talking about it. One of the symptom, cognitive fatigue and fatigue, are more strongly associated with what patient associated with a disease flare. So, and also we know that both fatigue, energy, and sleep and dry mouth are the most associated with activity constraint, with association score of 1, basically almost like a perfect association with those. So which I think is highlighting how important fatigue being a symptom from a patient perspective. Now also, fatigue is not just about for the patient, I already mentioned. There are a number of reasons why it's important for healthcare provider and society, because fatigue in general is also associated with many adverse health outcomes. There is a paper coming out in the last 2 years. So overall, the odds ratio, which means the improve in likelihood, so all adverse outcome is about 1.3 to 3.1 higher, fold higher. And even the increased risk is more than 2 times as higher, that they are more likely to die in somebody who got fatigue compared to those without fatigue. And all the other figures you can see are listed in here. Another thing is about disability in activity of daily living. The overall risk is almost like 4 times higher in people who got fatigue compared to those without fatigue. Now, so the next point that I want to briefly address is what actually causing fatigue. Now, of course, this is going to be extremely challenging. I'm not going to give you any answer to it, but I just wanting to highlight something that we've been thinking about. But before we answer that question, so I'm going back into our own observation in clinic. So what are some of the things that we know about fatigue in terms of the what happened in patient with Sjögren telling us? So first of all, we know that not every patient with Sjögren have fatigue. I have some patient who are living almost like a perfect life. They don't really have any fatigue at all. Now, we also know that fatigue generally correlates poorly. Now, it doesn't mean that there's no relationship. It's just that these relationships are not very good. So sometimes it correlates with disease activity, but sometimes it doesn't. So the data are just very inconsistent, or at least the association is quite weak, which means that there may be some other factors involved. Now, at the moment, as far as we know, we don't have very good data, but overall the natural history, i.e. over time, what people's fatigue tends to be like, it's not like if you have longer the disease, you get more fatigue. Not necessarily the case, isn't it? So you may have fatigue all the way along. In fact, we have some data to suggest fatigue may even be improving over time. Now, whether it's because patient actually coping better or because they no longer need to go to work, they can retire, they can take their time. So there's no real correlation, strong correlation about the natural history, about disease progression and fatigue. Now, we also know that fatigue, although again not always, it's not just happening on its own. So often patients also have other symptoms such as pain and sometimes low mood. Now, we don't know whether it is the cause or just they cluster together or they are the consequence. Now, we also know that the response to currently available therapy tends to be very inconsistent. So some people seem to respond, some people don't respond. Now, but having said that, of course, I know that some of your colleagues here who've got some promising early phase trial data showing you do able to improve some symptoms. So again, which means that we are obviously very interested in hearing more and looking into that further. Now, so what kind of inference or what kind of conclusion I can draw from all this observation is, first of all, assuming Sjögren, the central pathology, is due to inflammation and immune dysregulation, which I think there's quite strong evidence the disease is driving from that. What we could say is that the inflammation and immune dysregulation are likely to contribute to the pathogenesis, i.e. causing fatigue. However, inflammation or immune dysregulation on their own is neither sufficient, because if they are sufficient, then every single patient with Sjögren should have fatigue, which is not the case, nor necessary, because we know that sometimes even if you treat all those immune pathology, fatigue can still exist. So therefore, there is something else that's going on. So therefore, the other conclusion we can draw from this observation is that there are likely to be additional mechanisms involved in the causes of fatigue. And then I of the disease. And then the final question actually didn't show up quite well on the slide. I think it's maybe the lighting. There's a very, very grey faint point in here, is that there may well be some different type of fatigue as well, which we need to think about. Okay, so what do I think about the overall pathophysiological model of fatigue? So first of all, we think about persons. So we know that in Sjögren, which is due to immune dysregulation, so I would say that any kind of inflammation or immune insult to the body would be, of course, causing various autoimmune conditions, including Sjögren. And those inflammation can cause pain, fatigue, and depression. But of course, this is in the acute setting. But whereas what happened is that in a setting where things become chronic, which is like in Sjögren, that the inflammation are continually unabated, then the body are likely to develop some kind of immune regulatory or other adaptive mechanism going to come into place to try to restore the changes in the immune system. And I think those kind of immune regulatory mechanisms can also contribute to fatigue and also can contribute to other changes in mood or other symptoms such as pain. And often, I think in some individual, potentially, where those immune regulatory or other adaptive mechanisms become defective, then what happens is that they have their own perpetuation cycle of fatigue, pain, and depression without actually relatively minimal contribution from the information itself. So the next question is, what are those potentially additional mechanisms that could be involved? So a lot of different candidates has been being proposed, so I'm not going to go through every single one of them. So, people talking about, neural, metabolism, the CNS changes, talking about the autonomic system, the hypothalamic, pituitary, adrenal gland axes. We're talking about circadian rhythm, sleep, depression, anxiety, pain, but also some of the metabolic pathway, cardiovascular, respiratory fitnesses. And all these things, I think, are likely to be potentially either related to information on its own, but also they can all contribute to fatigue, and they all, I think, related to each other. So that's why it's making it so difficult to actually understand fatigue, because there are so many complex interacting mechanisms at play. Now, so the other thing is thinking about different stages of fatigue. Well, in my view, I think information probably play a much bigger role in the initiation of fatigue. But actually going on when the disease is being established, I think that other factors such as the genetic or environmental factor, that including previous illnesses, trauma, etc., those things can also contribute to fatigue. And particularly, I think they may play more a significant role in the maintenance of fatigue. And whereas when there's this disease flare up and when there's extra information, then the information may play, again, a more prominent role. But these are just my hypotheses, by the way. Now, so based on all this current understanding, albeit incomplete, I mean, just like the lady just said, we got a problem, but we need to start dealing with it. So even though we don't have a complete picture about what causes fatigue, we need to use the information that we have now to try to manage fatigue as much as we can. So one way that currently, how I approach it in my own clinical practice would be try to, as best as I can, to actually using the framework that I just talked about, the various contributing factors of fatigue that we know about, and to think about what are those factors. Could they apply to the patient sitting in front of me? And then I could think about, well, is that because there's a lot of information going on? Then I'll be thinking about, of course, treating the information with whatever tools that we have available. If there's a lot of mood problem or pain, we can think about different way of approaching this. I'm not going to go through all the different list. And then if there's problem with sleep or circadian rhythm problem, we can address that using various different approaches. And similarly, if we're thinking about, if there are problem in terms of metabolic or cardiovascular respiratory changes, we can think about way to approach it. If they're thinking about a CNS neurotransmitter pathway, there are ways that we can think about that. And similarly, we can think about the XPA axis and also the autonomic dysfunction. So I wanted to mention about, again, thinking about today and tomorrow, I want to mention a couple of new treatments that are being published recently. Now, of course, I know that there are more recent data as well. You'll see some of the abstract in EULAR, and there will be abstract coming up in ACR. But I'm just talking about one of the therapy that I'm involved in the phase 2 clinical trial, which is called RSLV132. In this particular treatment, which is targeting the RNA fusion protein, targeting the initiation of the interferon response. So in this small phase 2 study, in fact, we can see that this particular treatment able to improve mental fatigue significantly. But also we can find some objective improvement because these people are able to perform a neuropsychological test called digital substitution, symbol substitution test. You can see that those people who are actually taking the active treatment are able to do this test much quicker than those people who are actually only taking placebo response. And similarly, we run a SAM-controlled clinical study looking at non-invasive vagus nerve stimulation. Again, we can see that those people randomized to receiving an active device, they can actually have a significant improvement in their physical fatigue score, whereas those actually randomized to a sham vagus nerve stimulation device, there's no change in the physical fatigue score, which again has been recently published as well. Now, so in the final section, I'm just going to also mention a little bit about how do we measure and also monitoring fatigue, because that often is a very difficult communication in a clinic setting. People were telling us they're fatigued, but actually, how do we know are the fatigue actually improving or getting worse? Because without that kind of tools, we can't really trying to assess any treatment response, isn't it? Without an accurate and reliable tool to assess fatigue, we can't really work out whether any treatment are actually effective or not. Now, let's come on to some of the things that we need to think about. Now, although we talk about all this fatigue problem, but actually, I can tell you, as far as I know, there is still no agreed definition of what fatigue is. Which means that what you talk about fatigue and what I talk about fatigue may well be not exactly the same. We may be very likely talking about similar phenomenon, but we don't necessarily say that we're exactly the same. Now, one thing that I know, well, I hope that the people sitting in here would agree with me, I think the fatigue experience by patient with Sjögren is not the same, qualitatively, it's not the same as fatigue you experience by otherwise healthy individual, before they become ill. So some of the key features, I would say, from listening to our patient is that they're generally more unpredictable. They can't tell why they suddenly get so fatigued. They can be very variable, and they can be very profound, which means this fatigue is not you can just shake it off. People were telling me that they will have to stop the car while driving and rest for half an hour before they can continue on the journey. And also another thing is they don't improve with rest. If I go and tell my patient, go and have a good night's sleep, they're going to slap me in the face. They say, well, actually, it doesn't work. Don't tell me that. I know how to rest. Now, but however, in research, and often what we do is that actually fatigue is often defined by a particular questionnaire that we use. But even if we are using the same questionnaire, there is no agreed cutoff value, and they can be very, very variable between what is fatigue and not fatigue. So i.e. there's still a lot of improvement we need to make in terms of getting to a grip of how we can do fatigue research and measuring fatigue. And then the next question I think is important to think about is, are there any different type of fatigue? Now, I think this is still debatable because we know that fatigue is often very common, not just in Sjögren, but also actually in many other rheumatic and also non-rheumatic diseases. And also then the question is the fatigue in Sjögren different from fatigue, let's say, in rheumatoid arthritis? My sense is that probably not. And then the other thing is thinking about, do we really think that mental fatigue or physical fatigue, or some people use the term central fatigue, peripheral fatigue, are they really completely different phenomenon? Or are they actually the same phenomenon, but you have a different dimension or different facet? And again, my own view is that I think they are the same phenomenon, but with different facet, because I don't often come across patients who only tell me you just have physical fatigue and the mental fatigue is completely normal, no fatigue at all, or the other way around. So it's very uncommon, I think. So I suspect it's probably the same phenomenon with different facets, but of course I could be wrong. So the way that at the moment, we published a review article in Nature Review Rheumatology a few years ago. So the way that at the moment, at least from my research agenda, I'm currently defining fatigue as a multidimensional phenomenon in which there are physiological, cognitive, motivational, and emotional state of the body are being affected, resulting in impairment of the individual ability to function in their normal capacity. So probably going back into some of the question about asking, what would be your scale 1 to 10, what can you do, what can you not do, kind of question, really. So therefore, if we're thinking about that then what are the challenges? So firstly, I think because if you're talking about fatigue being multidimensional, so we need to think about making sure we're covering all the different aspects. And then fatigue, of course, are we measuring about how severe they are or how they impact on people's life? Because that may not necessarily be the same. And do we have a measurement that can capture all the variability? And then if we are thinking about it, they're so variable, how do we capture it? Do we going to ask them how they feel at that time? Or are they trying to ask them how they average over a period of time? And then what is a reasonable average period then? And of course, we need to think about the confounders, because I talk about fatigue often come with many other symptoms. And then it's about how do we place the importance about subjective response, or how do we observe or some kind of objective measurement of fatigue. Now, so I'm going to illustrate some of those potential problems with the current questionnaire-based assessment. So let's say in the fatigue severity questionnaire, which is often being used, but you can see in this actually questionnaire, there's actually very little question to talk about different dimensionality of the fatigue. So for example, mental fatigue is not really properly assessed in this questionnaire. And then in here, talking about in the past week, but of course, is the past week is the right approach, or should we be thinking about shorter or longer period? And then thinking about the severity or impact in here, talking about the fatigue among the most disabling symptom, interfere with social life. So, you know, this is to think about what kind of confounder it could be, because we know that if people who got depression, it will affect those who score quite severely. And then finally, if you think about question 2 and 3, could we potentially, instead of asking the patient to report on a score, they may be able to assess using a more objective measurement of that. So one of the potential novel approaches you can think of is that in here, in the fatigue impact scale, am I running out of time? Yes. Yeah, okay. So I'll quickly use that. So basically, you can think about there may be objective way of, you know, assessing some of these symptoms, and similarly, some of the neuropsychological tests can be potentially useful. And then we have done some early studies showing that based on some activity and also ECG measurement, we can actually find some, using AI approach, we can address some of those, potentially find some solution to measuring fatigue. And we are now doing an IMI project looking at this called IdeaFast, which is currently running the study with over 2,000 patients that we're recruiting to. And so that is basically what I'm going to say. I think I can skip the conclusion slide, really, and I think I already talked about those already. So sorry, I'm running out of time. And I'm just going to thank you all the teams and people who are supporting me. Thank you.
Thank you so much, and sorry that I...
No, sorry, I just talked too much. Stop me, you know.
Are there any questions?
Hi.
Fine, thank you. It's not really a question, but just to comment, because many years ago, maybe you remember, we performed a rituximab study. So it was negative for the primary endpoint, but it improved the fatigue. So, yes, and statistically, so I think there is something, immunity, inflammation, something, and we improve the patient with this. Well, of course, it's not sufficient to use this treatment for that, but that means that blocking immunity do something.
Yeah, and I'm sure you're aware of the, you know, the presentation at EULAR from some of the other, you know, clinical, drug in development. There's some improvement as well. I think the whole point is that I think there are other things. So information may treat certain degree, or maybe it's treating certain group of people, but whereas other people may or may not be improving. So it's about identifying the right target as well, I think. Yeah. Okay, thank you.
There's another question, sorry.
It's not a question, it's just a common as a patient that I'm living with fatigue. Okay, so you as clinicians, you have to have in mind that patient having fatigue, when they are having some other treatments also, they are becoming better. I mean, when they have physical activity, their fatigue is becoming better. And when we are better on our mental health, the fatigue, again, is better. So it's not only with treatments or with disease issues, but it's also changing our lifestyle. Will improve the fatigue.
I fully agree with that. Yeah, thank you for sharing.